move a little bit into our other roles. You know, you and I both had various roles as people who train other practitioners, not just social workers, but people in other disciplines. And I'd love to hear from you, like, in a supervision setting or a training setting, like how you bring CBS principles or psychological flexibility principles to those contexts.
Well, I think it really applies nicely with doing supervision. So for most of the time that I was working in primary care, the actual setting was a family medicine residency program. And so there was the training of family doctors, but then there was also students who were getting their master's in counseling. And focusing on them, I would say that the process of learning how to do therapy is, it's kind of crazy.
Right.
I mean, when you think about it, oftentimes, you know, students are relatively young, don't have a ton of life experience, may or may not have experienced any therapy in their own lives. And if they have, it's getting more and more likely that it's ACT, but over the years, it was not that likely that their experience or their exposure was to ACT. And so, you know, I think you learn a lot about psychology and a lot about therapy, but it's hard to really know, like, what is it actually like to be in the room? And I think the amount of stress and anxiety and evaluating yourself and comparing yourself to other people are, you know, it's really, it's you know, it's to be expected. So I think that ACT really lends itself nicely to helping students. And for me, it's about creating an atmosphere of, you know, I think you were saying it earlier, like, you know, just make mistakes. And so I think that, you know, if we can help students to be safe and productive and make contributions to their clients, but still be willing to make mistakes, which I think is a hard thing to sort of figure out if you're a student, you know, but I think if we can help them do that, it can be really useful. And I think the clients still end up getting a lot out of it. And the students really learn a lot from how to be with themselves. And you actually told me something, and you'll have to remind me what the exact phrase is, but, you know, we were talking about, you know, that if you don't have clients to practice ACT on, that's okay. Just practice it on yourself, because there's no end to the opportunities to do that. And I think that probably students that I've worked with probably have learned a lot more from our taking ACT and applying it to their own lives and to their own experience of learning how to become therapists, and then learning how to generalize that to their clients. I think that probably has been a really, you know, made a major impact. Plus, I would say that it creates for an incredibly wonderful environment of support and therapeutic love. And, you know, it's just like it creates the kind of place that I want to work in. And so I really, you know, find the influences of contextual behavioral science on that, creating a wonderful workplace is just awesome.
Yeah, you know, it's interesting that similarly, I do supervision for people outside of my discipline. I do supervision in the last couple of years. It's been mostly actually for psychiatry residents having their first experience of psychotherapy, which I think is what you were saying you were doing for some of them as well. And I find that in addition to all the things that you're talking about, like modeling a certain kind of openness and flexibility and compassion and gentleness towards their own experience, which helps them to kind of bring that to the work that they do with clients, I think it's interesting to like bring in the behavioral principles kind of undergirding ACT to help them with assessment. I'm sure you've probably seen this, that what we would say about psychiatry assessment is that by and large it's topographical, right? It's looking at the surface of signs and symptoms, the constellation. You know, is it, you know, sleep plus guilt plus low mood for 2 weeks at a time? And so they are really good diagnosticians by a kind of DSM model, kind of better than I'll ever be. Because by the time they get to that, they've done it so many times in an emergency room with a lot of really hard cases. But they're not used to thinking functionally. Like, what is this behavior about? Like, it's a self-harming behavior, therefore it is possibly helping to meet the criteria for borderline personality disorder, but then pause. What is the learning history that brought about this behavior in this person's life? And what purpose does it serve to soothe their emotions, to communicate with other people, to self-validate their own emotions, like all the various things that it could be about. And they're not used to actually asking those questions. They're more likely to say, if they have some understanding of the function of a self-harming behavior, for example, that like, well, it's about self-soothing. Like, but without kind of doing the assessment that looks at what are the circumstances that give rise to the behavior, what is the behavior, and then what reinforces the behavior, the kind of ABC functional assessment of ACT. And so I think that's always like the mind blower when I'm training, is like trying to introduce them to that kind of perspective, which is, I probably am making a little bit of a straw man out of the psychiatry residents because they're incredibly smart and sophisticated. So it's not like they've never thought about these things, but they've never had to really think about them in a really sustained way because their skill building has been in another area. And so I always find that kind of like the fun conversation we keep having over the course of a semester. And what do you think the behavior is about? How did you assess what the behavior is about? What was reinforcing that behavior for the client? And then what might you do as a practitioner to help shape that behavior in the client's life? The other thing, just to add on to that, is that I don't think it's just the field of medicine. I think it's all of us in mental health. We tend to think of problems as residing exclusively inside the person. Like that their depression or their borderline personality is like a problem inside them. And I think this is, again, where the CBS perspective and the social work perspective kind of dovetail in kind of beautiful way, because what we say in CBS and what the social work perspective is that you develop problems in interaction with your environment. And so what's happening right now in the context might be evoking this behavior, and that might be something you could kind of shift. So I'll often say to the psychiatry resident, like, so what were you doing in the room that might have helped to evoke this, this withdrawing, this exploding at you, or this acting aggressively, or this like avoiding? Like, was there anything that you did to contribute to that? Like in a totally non-pejorative, non-judgmental way, in a way that they often haven't thought about, because they're often looking at the patient, if you will, as a single unit, not a unit in interaction with the rest of the world over time. So that's always a fun conversation to have too. So at that point, we haven't even gotten to like, what is acceptance or diffusion? Because I'm not teaching them ACT, I'm teaching them the basics of psychotherapy. But of course, because it's me that gets them ACT along the way.